let's talk about the pandemic. Oh, first of all, introduce yourself. Just with your name and position and that.
Well, I'm David Smith. I am the program director of the North Colorado Family Medicine Residency Program. And we here in Greeley, Colorado, have a great many of our graduates go into rural practice. I also am the director of residency programs that are offshoots from our core program in both Ray and Sterling, Colorado. And pretty much all of those graduates go into rural practice. So I've always had a big heart for producing rural family doctors. That's really my life mission.
Right, and as you said, you're a rural guy yourself.
Yes.
And so this is kind of what you've done your whole career. How long have you been at NCFM?
I'm just shy of 20 years now.
Which is just amazing.
Yeah.
Because the usual, what's the half-life of the usual program director in family medicine?
It's about 4.5 years.
Yeah, okay.
Yeah.
So you have beat the odds.
I think so.
And to what do you attribute that?
Oh, let's see, that's a good question. I am not a bossy person at all. I'm not in this position because I like to lord it over others. That's quite the opposite of how I maneuver life. But I had always wanted to be faculty here, even back when I was a medical student. And the reason was this program just has this terrific reputation forever of producing lots of really strong rural family docs. And because that was my vocational mission, I thought, man, if I could be faculty in Greeley someday. But why I've lasted, I think, well, it's a great program. It's very rewarding. This year, tomorrow, I'm graduating 11 resident docs, and 6 of them are going into rural practice. 6 of the 11, and one of them is staying on as faculty here to help us produce more rural family doctors. So that's an example of why I love working here, love being in this program.
Yes. Thank you. So, how has it been these times since the first inklings of the pandemic up until now? How has this affected you, and how has it affected the program? How has it affected the residents and the staff? I mean, as you know, I was on the faculty for 10 years, yes. And I never wanted the director's job because of all your constituencies, who are often at cross purposes. So tell me about how this has been for you and for your various constituencies.
Yeah, well, that's a great question. It's something I've thought about quite a bit. Back in, I'm not sure, January, February, it seemed like a far away phenomenon that probably wouldn't even come and affect us here in Greeley. And then in March, it certainly started to affect us, and it affected our hospital tremendously here in Greeley. We had lots and lots and lots of patients with COVID-19 in the hospital and in the ICU on ventilators, but we had very few other patients. In other words, the sort of conditions that normally are taken care of in the hospital, those patients sort of disappeared. I think the public in general was afraid to go out, and that included heading to the ER or to their clinic. And so at that point in time, my thought was, how do I keep running a family medicine residency program when the only patients there are to take care of have COVID-19. I didn't want to become somebody who only trained people to be a COVIDologist. I needed to figure out some way to continue doing broad spectrum family medicine training, and that probably kind of threw me for a loop for several weeks. I'm not sure how long, 5-ish weeks probably, and we had probably half of our resident doctors continuing to work in the hospital, and basically taking care of almost exclusively non-COVID patients, because the other doctors, the hospitalists, for instance, were only taking care of COVID patients.
So they picked up the slack for.
Yeah, we tried to pick up the slack. And very early on in the local pandemic, I was put on a committee called the Surge Planning Committee, and representing the residency. And this committee, initially, we met every day of the week, 7 days a week, and it was about 2 hours a day. That was in addition to lots of other meetings that I was also having. But that was pretty intense. And through it, I was able to assign willing faculty to work in the intensive care unit, lots of our resident doctors to work in the ICU. We had a pretty large cohort of resident doctors that were contributing to a sort of on-the-fly research project with COVID-19 activity in our hospital.
Say some more about that.
Yeah. I wasn't involved in it, but certainly heard about it a lot. They basically were working the medical records to gather up all of the data possible on what sort of people are being hospitalized, what are their demographic characteristics and such. And so they have been quite active with that, certainly much more so when we had, roughly 100 COVID patients in our hospital. Now that it's down to, around 10, I think it's probably a less time-consuming task. The other half of our resident doctors, we were primarily having work from home, which kind of makes me cringe. I don't think working from home is the best way to learn to be a broad spectrum family doctor. But they were doing telephone visits and eventually the audio visual type of not visits. We eventually were able to move them back into the clinic, but it's been not an easy thing to try to get back to business as usual. Our clinic is close to being our normal amount of activity, but we're still a little shy of it. I think there's a lot of patients that are still afraid to come to a doctor's office, even though, of course, we're taking all of the precautions that we need to be. The hospital has become busier. One thing that was super positive, though it was pretty anxiety provoking to be on this surge planning committee, meeting with administrators, intensive care doctors, infectious disease doctors, hospitalists, every day. Basically the reason I was on the committee was to help contribute to the effort with our resident doctors and our faculty doctors. And I think I think our committee especially developed a really good rhythm. And we were, I think, sort of miraculously able to work well together to meet the need. It was really pretty rewarding. And as we went into the process over the many weeks, I would hear more and more kudos of our resident doctors, of our faculty doctors, and that is not always the case. So it
Oh,
was
really?
it was really very rewarding, very rewarding, and and so you have this terrible pandemic that turns everything upside down. But one of the great things is how much North Colorado family medicine is appreciated for our contributions these last few months. So that I think it's terrible to say, it's all worth it, because it's still an awful disaster and so many lives lost. But it is great when you can have a awfully hard time with a very nice side effect outcome there. So.
So it sounds like, and these were the leaders, many of whom are still on the front lines, because that's how it is in medicine with the clinicians. But it sounds like there was a greater sense of community
Mm-hmm.
than
that's
what
very
has
true.
been the case lately.
Yeah, very true, very true. And that is the greatest positive to come out of it here in Greeley, I would say.
How long did you all meet on the search committee?
Well, we're still meeting.
Oh, you are? Not every
Yeah,
day, though.
Yeah, it was every day of the week. It was 2 hours a day, and now it's once a week and about 10 minutes. Yep. And it's just sort of gradually gotten to that.
Mm-hmm. And are you meeting?
Yeah, we're still meeting. We're doing it's Skype meetings. Yeah.
Uh-huh.
Yeah. So we don't have the video,
Mm-hmm.
but we have the audio. Yeah.
How well, now that you all know each other well, that's probably fine. How do can you see ways to build on what has come out of this in the medical community?
Yeah, I think that what is being called virtual visits is certainly going to be something that will be continuing. It won't be the majority as it was for a month or two, but it's a nice, effective new way to take good care of patients.
And how have the residents responded to all of this?
Yeah, that is something. It brings a big smile to my face, because I'm so proud of our resident doctors. We work very, very hard to get not only smart doctors, not only hardworking doctors, but we work really hard to get resident doctors that are very high in altruism.
Mm-hmm.
And when I meet with the other Colorado family medicine program directors every month, what I've been hearing in recent months is, yeah, we've got this subset of resident doctors that are refusing to see patients. They're refusing to do this. They're refusing to do that. It was a subset. But all of the other programs were kind of complaining about that. And I had not a single case of that happen in our program. And it's something I'm very proud of. Our resident doctors really stepped up.
So if you're graduating, is it 3 in a is it 11 in a class? So you have 33?
It's 11 altogether with our Ray, Sterling, and Greeley-based programs.
Okay. How do you pick for altruism?
Yeah, well, we have a group of us on the faculty primarily that scour the applications for signs of altruism. So, the Gold Humanism Award, volunteerism in homeless shelters and free clinics and such. All of those sorts of activities probably portend a higher amount of altruism in an applicant. So that's a real high attribute that we look for.
Now, I sat on the medical school admissions committee for a year. I'm sorry, there's a jackhammer outside my window, so I keep on muting.
Oh, I haven't heard it.
Oh, good. That's good. So I sat on the admissions committee at the medical school, and what I found was I was surprised. There were a number of those applicants who I thought would have already won a Nobel Prize.
Yeah.
Because of how they know how to make the record.
Yeah.
And they all cared about, world peace and, stamping out disease and all of that.
Mm-hmm.
So I'm glad you guys have figured out how to do it.
Yeah, I feel like we do have a pretty good handle on it. It's not how long your CV is. It's what you prioritize in your CV.
And how's it been for the faculty?
Well, that has been interesting as well. I would say that we have a very, very strong faculty. Not only are they brilliant, but they're hardworking and they have such a great skill set. They are all leaders, and that is really handy in a family medicine residency program. But you can also, when times get tough, sometimes you can have a little butting of heads. And we certainly experience some of that. And then it's my job as the peacemaker to get people to work well together. And hopefully I've been successful with that. But yeah, it was stressful. It was stressful. We had some of the faculty doctors that were pretty busy in the ICU, not able to, well, let me say when they would be able to go home, they had to have physical distancing from their own family because of how much exposure they were getting in the hospital. And so that's a harder life. But I think the faculty certainly joined me in being very much on board with trying to continue being a broad spectrum family medicine residency program. In other words, we were glad to deal with the majority of the non-COVID patients in our hospital, whereas we typically have one medicine team taking care of adult medicine patients in the hospital. At the height of the pandemic in Greeley, we expanded that to 3 teams.
Wow.
And so instead of taking care of 15 to 20 patients, we were up there in the 45 to 60 patients.
That's crazy. And your teams are a faculty and 2 or 3 residents, right?
Yeah, exactly. And so that enabled us to not only be good team members to our medical community here, mm-hmm. we were picking up the slack. In other words, the other hospitalists were taking care of the COVID patients. My desire was to keep taking care of people with congestive heart failure and pneumonia and knee replacements and
all the things that they're going to be seeing for the rest of their career.
But other more bread and butter things. So,
yeah.
So it really worked out well, and the faculty did terrific with that.
Yeah. When the faculty butted heads, were the issues just about who does what?
Yeah, sometimes it was. Every individual's comfort level with a pandemic is different. And so some of our faculty were placing a tremendous priority on the physical distancing, such that they preferred to only help teach in a virtual format. And that was allowed by the ACGME, but it may not always be as good as teaching in person. Other faculty recognized that and very much wanted to teach in person while masking and physical distancing. And so that was probably the biggest point of contention, was those different comfort levels with trying to limit exposure. And it eventually came down to basically, after a lot of discussion, just making a decision and doing it as safely as we could to get back to in-person teaching.
Mhm.
Several of our faculty are older chronologically, and so at greater risk, and had to include that into the equation.
How about the staff? I mean, you have a lot of staff. You have to run a big, busy clinic.
Yeah. That's been one of the harder issues, I would say, for a variety of reasons. Because we here at our clinic were seeing far fewer patients than normal. We had required unpaid leave for our staff. And it varied a bit as to how much. But for instance, let's say that a medical assistant who is not making much more than minimum wage is asked to only come to work 3 or 4 days a week instead of what they signed up for, 5 days. That's quite a hardship for them. And no one was let go. No one was let go at all from our clinic and from our organization. So I'm glad and proud of that. But we did have to have people take some unpaid days off, and that actually still is taking place at this point, though we're getting close to bringing everybody back full time. But that was a difficult thing, and still is a bit difficult. Another thing is mask fatigue. Many of our employees are perfectly adherent with the requirement to be masked when within 6 feet of others. And some don't like that. They don't like that. And that has caused some points of contention at times. And I've tried to address that in a kind but somewhat firm way. And I think we're not done with that mask fatigue yet. One of the staff asked me this week, Dr. Smith, how long do you think we're going to have to do this masking? And I said, well, no one knows. But if I were to guess, I'll bet it'll be another year. And she almost fainted. So, yeah, that you're actually on mute right now.
How are your residents and faculty doing about masking, though?
Yeah.
As you know, way back when I was director of continuing medical education at the hospital.
Yeah.
And so when there were things about doctor behavior we were supposed to address, that crossed my desk. And they asked me to do a program on hand washing.
Yeah.
Doctors are the worst at hand washing of any of the staff. How are your doctors doing about masking?
I think the faculty doctors are doing quite well. As I think about all of them, I would say that they are all quite well adherent to the policy. And then the resident doctors, I would say, are a little bit more lax. It might simply be that younger age.
Immortals?
Yeah, being immortal when you're younger, that probably plays a role in it. I've had one resident doc that twice now I've come up upon him in the clinic, and he's had his mask down here, protecting his thyroid. And and I've just said, mask up.
Yeah.
And he gets it up right away. And, I don't yell at him. And from time to time, I'll kind of send out a page or an email reminding everybody, this is just what we need to do right now. And I think one of the most helpful things in communicating that message is that the main reason to wear a mask is if you've got the virus coming out of you
Right.
in your breath,
Everybody else.
you don't want it to get to that other person over there that's 3 feet from you.
Yeah.
So you're doing the right thing by protecting the others around you when
Right.
you mask. It's not so much about protecting yourself; it's protecting others, and that is a good way to message that, I think.
Well, especially with a room with a program full of altruistic people.
Yeah, indeed.
Yes.
Yeah.
So here's another matter, and you don't have to get too far into the weeds about this. But how has it been managing the residency or the whole program? And of course, you have it's so complicated. You have a whole program. You have a practice. You have people in far-flung places. How have you been doing financially?
Well,
By the way, that's another reason why I didn't want to be director.
yeah. Yeah, I am aware that our organization has had a tremendous financial hit. Tremendous financial hit. Huge. I also am aware that our organization, being a large organization, is very, very savvy with taking advantage of the financial bailouts and opportunities that are out there.
Mm-hmm.
And so that helps a lot. If I was a rural doctor, like back in the early 1990s, I'm in a little 4-doctor practice in a town of 4,000 out in the middle of nowhere, and we were independent.
Mm-hmm.
And if this had happened at that time, I don't know that practice could have survived.
And I think a lot of practices are going under, and
Yeah.
hospitals, especially rural ones, are teetering.
Mm-hmm. So I think we're very fortunate in this situation to be part of a large organization with lots of savvy on taking advantage of government bailouts and such.
So they're good at running interference for you, and you've got the depth of support.
Yeah, they're taking care of that. It's not something I've had to deal with. Now, the only financial thing that I am dealing with is getting more of our faculty, more of our resident docs in clinic, doing the virtual visits, kind of mandating that. And so, but I think that with I think the real pitch for that is, until we get a lot more patients coming in to see us, our medical assistants are having to take an unpaid day off a week. And so we're all very sympathetic to that. So that incentive works well with our group.
Right now, and I should say that the date is June 26th, 2020. Right now, what percentage of your patient visits are in person? And then what percentage are remote? And of those, how many are audio and how many of them are audio and video?
Yeah, I would say that telephone alone visits are, at this point, very rare. One a day, let's guess.
Oh, wow.
And I think the audio-visual remote visits are probably only around 10% on this day. In-person visits would make up the rest of it. But we're still only probably at about 60% of our productivity and accessibility compared to a year ago at this same time.
How about nursing homes? Residents had to take nursing home patients always, and you had,
yes,
it was just a few, as I recall.
I would say that each of our Greeley-based resident docs averages around 3 nursing home patients. And most of those are at one nursing home here in Greeley
Mhm.
that was very, very hard hit by COVID-19. And so that census of patients for our resident doctors to take care of has plummeted.
Right. So they're just not their local staff or their hired doctor, chief of staff is who's overseeing their care right now, right?
No. Well, actually, one of our faculty is the medical director of our nursing home.
Oh, that's great.
Yeah, and so our resident docs take care of pretty much all of the patients in that nursing home, which normally has a census of around 100, but right now it's down to about 17.
Wow.
Yeah.
Have there been a lot of deaths?
Oh my, yes. Mm-hmm. Yes. Yeah. And one thing that was done well is advanced directives. So not
wonderful.
too many of those deaths took place in the ICU. Most of them were comfort care remaining at the nursing home.
Oh, that's good.
It is good.
Yeah. And also, the other hotbed in town besides the nursing homes has been the beef plant.
Yes.
Have you seen many of those patients? I know a lot of them go to Sunrise, and I've
Exactly.
people from Sunrise too. Well, and there's a resident at Sunrise, or two residents.
We actually have 2 per class now at
Oh,
Sunrise.
6? Okay.
Yeah.
Good.
So there's 6 over there.
So I imagine they're the ones who've seen the most of beef.
Yeah, oh, yes. Right? Yeah. Whereas the Banner Health clinics, starting in March and continuing to this day, are not seeing folks with potential COVID-19 in our clinic.
Mm-hmm.
So if a person has a fever and a cough, they're going to a Banner Health personal protection equipment clinic elsewhere to be evaluated.
And where is that clinic being held?
And they're not coming to our clinic. It is out at now they moved it once or twice over these many weeks. I believe it's out at Summit View Commons.
Okay.
71st Avenue and 20th Street. And our nurse practitioners provide care there on a rotating basis with other providers in town. So we've been very active there as well. But our clinic really has not been seeing known COVID patients. Sunrise, on the other hand, set up their own respiratory patient clinic right within their own building. They just sort of had it, down on the end of the building.
Yeah, that's a huge building.
And so they've been much more busy than our clinic with actual COVID patients.
Well, I sure hope. Oh, and well, so here's another question. How are you doing? Oh, by the way.
Yeah. Well, so I think the first few weeks really threw me for a loop. I am a personality that, and I'm very upfront with this, I'm a personality that tries to avoid conflict at all costs.
And you've got just the job for that.
and I'm a peacemaker. And so those first few weeks in March and early April, I was working from home because I'm older. I didn't always have the greatest Wi-Fi connection, which made it difficult to do these many virtual meetings. It wasn't impossible, but I would get dropped off about once a day. And being in my bedroom instead of here in my office, I just felt, I felt small, and I felt less powerful. Not that I need to feel powerful, but it was not comfortable, and I didn't feel very effective. And eventually, talking with a variety of people, I decided I need to get back in my office. I need to have a better computer connection, and I need to be more assertive. And I even had one of my faculty come in and very kindly tell me that he needed me to step up and be more assertive.
Mm.
And that was kind of an eye opener for me. Since that time, I am in a much better place emotionally.
Mm.
I've remained healthy the whole time. I'm seeing patients in clinic.
Good.
I'm precepting in clinic. I'm not avoiding things at this point, but I certainly am doing a good job of masking. Here's my favorite mask right here.
Oh, Wisconsin, of course. Badgers.
You bet.
Did you go to UW? Is that where you went to college?
And I'm doing the physical distancing but I'm feeling pretty good now, pretty positive. I think we have a big challenge ahead of us. And that is something I don't know that you would have necessarily heard about yet, but interview season for new resident docs is probably going to be done virtually.
How many do you interview now?
Say again?
How many do you interview now?
Well, it's a lot. We interviewed 128 this last year.
Oh, boy.
Yeah. And every last one of them was here in my office, not at the same time. But yeah, so doing it virtually is going to be tough. That's a big challenge. I think one of the best selling points for getting somebody to want to be a resident doc here in Greeley is coming to Greeley, seeing our clinic, seeing our hospital, meeting face-to-face with our resident docs and our faculty.
Mm-hmm.
And so a virtual approach is going to be much less effective, I'm afraid.
Have you gotten somebody to do a nice video?
I'm a little worried about it.
For your website? And kind of a virtual.
Yeah, exactly. That's what we're working on, is improving our social media and our website, so that we've got video on there for medical students to look at and see our nice facilities and meet our nice people.
On the other hand, if you have 128 people to fill 11 slots, if you have half as many interviewing to fill 11 slots, I have a feeling you'll still do pretty well. You don't have to worry about.
Yeah, we do well in the match. We typically don't go down very far on our rank order list. It varies year over year, but I think this last year, the lowest ranked person was maybe about 52 out of the 128.
Yeah.
And some years are considerably better than that. I think we were, like top 20 a couple of years ago. So
yeah,
we do well.
And in my experience way back when, there wasn't much correlation between how well the resident did and where they had been in our list.
Yeah, that's true too. Yeah. Very true.
Yeah. So I hope you find some ways to maintain this sense of togetherness, this teamwork. Obviously, you already have it at the residency, and you've spent 20 years developing that. But with the whole medical community, and the community in general, I applaud you for it.
Yeah, that's been a nice positive.
Yeah. Is there anything else you'd like to say, or remember? We're hoping this is going to be out there for generations. So you get a chance now to say something for posterity.
Well, I don't know that I have anything too profound, but this has maybe more than any other vocational adversity in my life convinced me that out of adversity, great positives can come.
Yes.
And that's been a nice surprise. Nice surprise.
Really interesting times to be
Mm-hmm.
alive and
Indeed,
coherent.
it is. It is, and I think the other thing is being part of this particular residency program has been highly rewarding these last 3-4 months because they've stepped up to the plate so well and with such good attitude. Really makes me even more proud of NCFM than I already was. And I was mighty proud already.
Well, thank you so much.
All right, Mark. Very good. Well, it was a pleasure.
Thank you.